Myths and the facts. Thank you very much for these kind words. In anxiety disorders, we'll talk about therapy and drug relation, but let's start with what each one does. We can approach psychological problems at different levels, spiritual level, neural level, psychological, physical, behavioral, and social level. As in all psychological disorders, there is not one single aspect to this, and one of those aspects might be in the foreground depending on the disorder. Sometimes it's the physical elements, sometimes it's the chemical elements. We have heard a set of different treatments for anxiety disorders, and we are seeing some new evidence for some of these disorders as well. We know that the approach is focusing on the functioning of the brain, therefore it's about the levels of synapse, the neuroreceptors, and this is the treatment modality. And if we think of man like a computer, if there is a problem related to this computer, it is most likely caused by the hardware. This is the approach. There is the environmental aspect, the perception, the emotional, the physiologic, and the behavior. So this approach is focusing on the physical and the emotional or sensory aspect. So the antidepressants have effects related to the physical and the sensory. So the antidepressants are desensitizing us, and some of the patients are saying, I know I'm supposed to cry at a funeral, but I don't feel like doing that. Some patients say, I wouldn't mind or care if a bomb went off next to me. And on the other hand, psychotherapies are focusing on the perception, thought, and behavior. And the psychotherapies or psychological theories are saying if there is a problem related to the functioning of this problem, it is related and most likely caused by the software, and that's what we are working on. As for combined treatment, which is my topic today, we talk about an intervention on both areas. So logically speaking, the more areas we can affect, the better result we can get, is the kind of thinking. But is that really the case? Psychotherapy and pharmacotherapy, considering some possible interactions, we can have an add-on effect, we can have an augmenting effect, we can have an inhibiting effect, maybe suppressing each other's effect, and there might be a reciprocation, is that no matter you give them together or separately, you will get a certain effect, not more than that. So all drugs have positive placebo effect. That goes for active drugs as well, and drugs can facilitate the effect of psychotherapy. Also, pharmacological treatment can reduce compliance in psychotherapy and might turn into a barrier for applying certain techniques, and it might reduce the impact of psychotherapy. Looking at the psychotherapy-drug relation, psychotherapy has a positive placebo effect as well. It comes from human interaction. Psychotherapy can increase compliance to drug. There was something missing from all the studies presented by Dr. Mandelo. So every patient who is on drugs also receives the positive placebo effect of psychotherapy, because during this process he's consulting with the doctor and he's getting recommendations. What about the other case, the patients who take psychotherapy only? Are they going to take the positive placebo effect from the drug therapy? Actually, no. And so the main recommendation these days is that patients use these drugs, and if they want, they can get psychotherapy as well. Of course, psychotherapy has biological effects, and it can work in line with the other approach in modifying chemical anomalies in the brain, and we are seeing some new neuroscience studies in this area. I'd like to sweep through the slides to make better use of time. Let's take a look at some of the efficacy studies. So I want to check the differences between combined use and separate use of these two approaches. This is the most comprehensive review, and this is a comparison of single drug therapy with drug therapy plus psychotherapy, the CBT plus drug. We have different impact sizes here, and there is the publication bias, and because of publication bias, all of the meta-analysis are coming with some shortcomings. In the Netherlands, they are using a statistical analysis to understand which are the studies that have not been published, and taking that into consideration, you are likely to see some different results. As for follow-up, the wellness is lost, the well-being is lost. This is an NIMH-supported trial, and the result of this trial is CBT plus drug is superior to single CBT. And also, if you administer placebo, it's also better. And so, in the patients who were given placebo, the well-being is preserved. But in the other group, the well-being is phasing out. So, if the patient is on drugs, even if they receive CBT, there are some data that this is reducing the efficacy of the drug. Here is another meta-analysis supporting this finding. Acute combination treatment is superior to single CBT, standalone CBT, but no statistically significant difference was found in follow-up. Looking at benzodiazepine CBT combination, I'm going to show you the result of this trial. Here we understand that there is a slight improvement with the combined administering of CBT and benzodiazepine, but in the good period that difference seems to be lost, and in the 6-month follow-up we see some better results. And this is a comparison of placebo plus CBT and placebo in the acute period, and in the follow-up those who receive placebo plus CBT are doing better. So interestingly, when you administer drugs, that effect is lost in follow-up, but the same is not the case in patients that receive placebo, because the patients are not associating their improvements with the drug, because in some of the groups the patients may also be aware that they are receiving placebo. So we can say that the patient's own assessment relating to drug use is also influent on the outcome of this approach. Here is another trial where 8-week combined treatment of alprazolam and CBT was approached, and NICE guideline. When we are listening to NICE, we have to bear in mind that people that are somehow related to drug pharmaceutical industry are not accepted, and therefore their approach is more prone towards the psychotherapy. And in panic disorders, psychological, psychopharmacological, and both treatments can be combined, and treatment is better, superior compared to. We understand that there is no difference with the addition of placebo, but compared to CBT plus drug, we understand that CBT plus placebo is superior, and we need to assess each patient separately. The American guideline, the APA guideline, it's also talking about CBT pharmacotherapy, says we do not know yet which is more effective on what patient. So if one of them is working, we should not do add-on. That's, I think, an economical advice. So I think there is a benefit to be harvested from adding therapy to the pharmacotherapy, but we cannot say the same for the opposite. We understand that on longer term, psychotherapy seems to be working better in the longer run. Also, combining psychotherapy to pharmacotherapy is going to reduce the risk of relapse, both during treatment and in follow-up. Looking at social phobia, therapy and drug, both effective. This study involved phenarcin, and it's the classical picture. If the patient has received psychotherapy, there is a reduced risk of relapse, and in social phobia, relapse is 50% in enhancing group and 12% in the therapy group. Also, for SAB, we don't have a trial showing the superiority of combined treatment over standalone CBT or drug. And for common anxiety disorder, the CBT is known to be an effective treatment, but also for anxiety disorders, the CBT, the anxiety disorder is known to respond lowest level to the CBT. So this is at a more personality level, therefore it's more difficult to tackle. So in common anxiety disorder, comparison of combined treatment and standalone CBT shows that the combination and standalone treatment are not found to be superior to one another. So because of a lack of clear findings, it's recommended not to combine the drugs. We should try standalone first, and if we cannot get a response, we can switch to combined treatment. This is related to toleration. Looking at psychotherapies, the dropout rates almost in all disorders, it's lower in the therapy in CBT. For common anxiety, 10%, benzodiazepine, 13%, antidepressant users, 33%. In panic disorder, we are seeing the same trend. And that is an advantage, I should say. Another thing is the cycloserine, which is a more recent development. When we apply exposure treatment with cycloserine, it is reported to improve the outcome in a trial in social anxiety disorder. Cycloserine is found to reduce the fear response, and this is sold in Turkey as well, but I deleted for you the company brand, and here you can see what's important here is a successful exposure, because if it's negative, then there is the risk of increasing fear with this drug. It's experimental treatment, and here you find a summary of all of that. In panic disorder, add-on benzodiazepine is usually not welcome. Alprazolam, it's the same, and both can have negative effects in the longer run. And maybe alprazolam could be useful in shorter term, but it's questionable for the longer term. Social anxiety disorder, we don't see any contribution.